Welcome to Gross Anatomy.
Are we live, Lauren?
We are live with Gross Anatomy podcast, where we explore the sights, smells, and sounds of medicine and how it pertains to pop culture, meaning books, movies, TV, and the world around us.
And I'm Dr. Jason Cohen. Today, that's who I am today. And who are you, Lauren?
I'm Lauren Taylor, and today we have a very special guest. Dr. Steve Rad is with us.
Yes, who I had to beg to come on the show. And
That's not true.
So actually, I've been begging you actually to join our practice, but that's a whole other thing. But so you're, I've known, how long have you been at the hospital here?
Oh man, I've been at Cedar since about 2007.
You're an OBGYN?
Yeah, so I'm an OBGYN, but with subspecialty training in Maternal-Fetal Medicine, which is also known as high-risk pregnancies, or perinatology, or perinatologist. It goes by multiple names.
So you're the like go-to guy when maybe there's like some major issue with like why would someone even call you?
Yeah, so we work with the general obstetricians in the event of a complication with the fetus or the mother. So perinatologists, we play a role in the office as well as in the hospital. So it depends on where we're being called to help. In the office, we're seeing both low and high risk patients. One role we play is, so our specialty, again, it's called maternal and fetal medicine. From a fetal perspective, we are doing ultrasounds, detailed ultrasounds to look for birth defects in the fetuses, and should there be any birth defects found, then we follow those women closely, those fetuses closely, to manage them during the pregnancy. Birth defects can be involve any organ from head to toe.
So you deal with some sad, upsetting stuff then.
Yeah, absolutely. Well, the majority, thank God, of patients are don't have birth defects, but we do get referred for, all the abnormalities as well. And so a big part of our practice is dealing with abnormalities, so it can be sad, yeah. And so we deal with fetal abnormalities. We also deal with, I also like to break it down between the mother, the fetus, and the placenta is an often way we break things down. And so we also deal with placental abnormalities. You may have heard of something like placenta previa or placenta accreta. We deal with fluid abnormalities with the fetus or the amniotic fluid, if it's too much or too little. And then we deal with any maternal abnormalities. So in the office, this could be patients who have pre-existing medical conditions, whether it be as straightforward as something like chronic hypertension or pre-pregnancy diabetes, to thyroid disease, to more complicated situations like women with, severe renal disease or different rheumatologic conditions, cardiac conditions, and they're pregnant. We also take care of complications that can occur with a mom as a result of the pregnancy. So there's pre-pregnancy complications, and there's pre-existing conditions, and then there's the pregnancy-associated maternal complications, such as gestational diabetes or preeclampsia.
What these days is considered like an old mom? Like what age is considered an old mom?
Yeah, so traditionally over 35 is considered what we call advanced maternal age, but that's become kind of the norm now. Actually, it's surprising to me if I see a younger patient, especially in the community we practice in. To me, an older advanced maternal age is, though by definition, is over 35. Over 40 or 45 is, considered an older.
Is there a certain age of a mom that automatically they're like, oh, you need a guy like Steve Rad on board?
Yeah, I would say that 40 plus range.
So pretty much any woman having a baby, at least in the LA area, sees someone like you during their pregnancy?
Correct. We see also the low risk patients. So one thing to understand, and it's good that you asked that. So what you're saying, like low risk, under 40 or under 35, are still at risk of developing, complications, birth defects, genetic abnormalities in the fetus, placenta abnormalities, conditions of the mom. This can happen at any age. So, or if it's not there to begin with, it's something, there is always a potential for pregnancy to become high risk. So generally, you'll see your general OB, and then they'll send you to the perinatologist for your ultrasounds. And then you get to know the perinatologist, and in the event something were to come up later in the pregnancy, you've already established your relationship.
You're the perinatologist?
Yeah, so that's the MFM, maternal-fetal medicine, perinatology, high risk OB. They're all
Perinatologist sounds so much sexier and better.
Yeah, the newer name. We're trying to move towards calling it maternal-fetal medicine, but because people still know it as perinatology, we go by that too.
Why are you trying to change the name? Branding?
It's just a newer. Since I've been practicing, it's been newer nomenclature. Also, maternal and fetal medicine to explain that we deal with both the mother and fetus.
And what you guys do is you guys are the experts at the ultrasounds, looking at the ultrasounds and telling if there are things wrong with the baby, right?
Right. And then exactly. And so we do detailed ultrasounds to look for birth defects. And this can be done as early as 11 weeks gestational age now.
So it's a very imaging dependent field. Like it's like you guys are like probably some of the best ultrasound people on the planet, right?
Yeah, yes, absolutely. Because you can do an ultrasound of a adult liver or kidney as well, but it's not moving around. There's not much, there's very limited things you need to look at with like a kidney or liver. When it comes to the fetus, you need to know every organ at every gestational age, and you have a moving object.
So have you ever done an ultrasound when the woman doesn't know something's wrong and you're like, oh my God, I see something wrong here?
Yeah. It's actually, believe it or not, kind of stressful for us because we hate giving bad news, and it's not easy, people come to our office. Everyone's kind of nervous because they know that we might find something. The birth defect rate is probably about like 5% or so. So fortunately, majority of the time things are fine.
That sounds high, 5%.
Yeah, but it's about around 5% or less. Yeah.
Okay.
And so people don't, everyone comes in very nervous, and it's such a sensitive topic, and to give someone bad news when it comes to dealing with like new life, it's very hard.
Do you consider yourself good at that?
Yeah, and the unfortunate other thing is that you have to do your ultrasound and then really wait to the end to give them the news, because let's say you find a heart defect, you want to make sure that there's no other defects in any other organ before you let them know that there's a defect in them, because A, they'll stop listening. B, you have to do a complete ultrasound to see if there's any additional abnormalities that might change the prognosis and genetic implications and next steps. And so if you give it away in the beginning or in the middle, whenever you find it, then the rest of the time she's probably crying or keeps asking you questions and you can't finish. And you also can't give proper answers because you don't know the full extent of things.
And then a big part of your job is kind of probably being therapist and counselor, right?
Absolutely. I mean, then once you give them the bad news, then it goes, into a whole new level of just sitting down with them and talking to them and running through different scenarios with them and next steps and getting multidisciplinary care involved.
Does it ever happen where you see something and it turns out you're wrong, either good or bad, either way? Or
we try to be very careful before we give anybody bad news. And if you can't tell, then we have to also be honest and say like, okay, I'm not sure that there's, there might be something wrong with the heart or the intestine or the kidney. I'm not getting good views. We have them walk around sometimes or change positions. Or, you say something like kind of borderline, or I'm not sure. I want you to come back in a few days or a week and let's take a look again. And sometimes you're in that situation, but you have to be 100. I mean, if you're going to give someone bad news, you better be 100% sure.
What made you decide to go into this field?
I actually had no intention of going into this field until I started medical school.
What did you think you were going to do?
I was actually thinking of becoming an oncologist or surgical oncologist, actually, kind of like you.
Yeah.
I went to UCLA for med school, and I skipped a few grades. So I was probably like 20 years old and I started med school. And the first or second week of med school, all the different clubs come to meet all the new, freshman first year students. And the OBGYN club came and they offered us to go to labor and delivery one night at UCLA, the old hospital, and shadow and see some deliveries or whatever comes up that night, to be on call with them, basically.
As a college student or med student?
No, med student. First year.
Okay.
First was like first week of med school. First or second week of med school. So I'm like, okay, that would be cool. I can tell my friends and family, I could tell my mom I went and saw a birth or something, So I went that night and I saw a birth and I was like, wow, this is really amazing. Okay, I never thought about this. And they asked me what I wanted to do. And I said, I'm thinking of surgical oncology. And then they said, have you heard of gynecologic oncology? And I said, no. And so they started talking about gyn-onc and what amazing surgeons they are, and that telling me all about the field of OBGYN and the OB part and how you can be primary, you do a little primary care, little office, you do OB, you do GYN, you can subspecialize in gyn-onc, and it's a little bit of everything, and you play a very special role. It's different than other physicians because you're dealing with women's health and new life, and honestly, that night I was sold. There was also
really?
one of the professors who later became my mentor. He wasn't OBGYN, and I mean, like, everyone did their research. Probably half the school did their research with this professor, and I had heard so much about him, and I was just, that night they sold me. I swear, Jason, I went there that night just so I can tell my friends that I saw a birth, and tell my mom and tell, just be cool. I was just like 20-year-old kid. I just wanted to be cool and tell everyone that I saw a birth. And that night, I was sold right away. Like, from that day on, I wanted to be an OBGYN.
Wow. Did you see many births that night?
And then I saw like 5.
Oh, wow.
And yeah, and then I got obsessed with gynecologic oncology, and that's what I wanted to do. And so all of med school, I started doing research, and I got to know every gyn-onc program in the country and where I want to go for residency. And then I did my sub-Is, and I came to residency. I ended up coming to Cedars-Sinai for residency for OBGYN. And I was ready to become this badass gyn-onc surgeon. And then the rotation started, your intern year and second year. And what I started to realize is that the surgeries were absolutely, unbelievable. And, they're great surgeons, especially the ones at Cedars. And I love the surgery, but then invariably these patients, we would see them in follow-up. They would be really sick. They'd be on chemo or radiation. They'd come back with bowel obstructions, nothing to do with the surgery, but their disease would progress after the surgery, or their surgery was done. So now they're going on to get the chemo. And I said, and then in the meantime, we're delivering babies on your other rotations or when you're on call. And I said, wow, this is really, and then I went to some of their conferences and all they did was talk about chemo and radiation. I'm like, wow, this is not what I had envisioned. I wanted to be a surgeon, and I didn't really think of the oncology part and the cancer part. I just wanted to be a badass surgeon. In the meantime, I started becoming, really passionate and in love with the obstetric side. And then in maternal-fetal medicine, you still deal with that critical care aspect, and it's really, really high risk at times, and life and death in just matter of seconds, similar to when you're in the operating room. And so an ultrasound, I feel like ultrasound, every time you do an ultrasound, is almost like it's its own operation. It's very technical, I see, because we do very detailed ultrasound. I can tell you more about that, but it's a procedure in itself. Once you really get in depth into ultrasound, you're really into it. It's really magical, and it's like doing an operation. Anyways, so I started falling in love with the obstetrics portion, and I learned, because here we're bringing in, it was like bringing in new life, and everything's more on the positive side, and then on the other side, I was seeing all this like sick patients, and it wasn't what I envisioned. And so then I learned about fetal surgery, in utero fetal surgery, and then I started to fall in love with ultrasound and maternal-fetal medicine, and I completely switched over. And then I don't know if you have heard of fetal surgery and utero surgery, and I was just fascinated by that. I mean, if anything is more badass than an oncologic surgeon is doing in utero fetal surgery.
Who does that surgery?
So there depends on where you are in the country or the world. Sometimes it's pediatric surgeons, but the majority of them are actually maternal-fetal medicine specialists who then subspecialize in fetal surgery. So I started getting really into falling in love with MFM and the fetus and in utero surgery. And I did my ended up staying at Cedars for fellowship. And then I went after fellowship at Cedars, I went to UCSF at a big fetal center there. And they did fetal surgery there. And then,
so you did fetal surgery.
Yeah, I got to participate. They have the fetal at the UCSF Fetal Center, which is one of the pioneers and where they invented fetal surgery. And then I did that. I was there for about a year, and I really wanted to come back to LA because I missed family and Cedars, and so I came right back. And then
how do you do fetal surgery? How do you even do that?
The majority of cases now, originally it was open fetal surgery. Literally, you open up you do an X-lap, you open up the maternal abdomen, and then you open up the uterus like you're doing a C-section. And
so it's exactly like the setup is exactly like you're doing a C-section?
Yeah. Yes, but it's more, I mean, yes, the setup is the same, but much bigger incisions, and the uterus is much smaller. You're doing it early gestational ages. So that's the old way.
Open up the uterus.
Yeah, the old way. This is the original way they were doing it, as an open fetal surgery. And then one common surgery is like spina bifida surgery. So you manipulate the fetus. You do a small, not a huge incision on the uterus, but they did a small incision on the uterus, bring the fetal spine into view, and you usually they have this special stapler, which at the same time you're opening the uterus, it makes it also hemostatic. And then they bring in a pediatric neurosurgeon to repair the spina bifida, and then you close back the uterus and inject fluid back in. You have to close back the amniotic sac. Nowadays, they still do open fetal surgery for spina bifida, but nowadays a lot of it's become more basically what they call fetoscopic, but it's very similar to, it's like laparoscopic underwater. And there are some newer techniques where they're putting in gas as well, because the morbidity is much lower if you do it, minimally invasive.
With scopes.
Yeah, with scopes.
Wait, so they go into the abdomen with a scope, the mom's abdomen with a scope?
Yeah, and then
they
through the uterus. And they go through the uterus.
So it's double scope.
They're very small scopes.
Wow. Have you done that? Have you had a chance to do that?
Yeah. So the most common procedures for something called twin-to-twin transfusion syndrome, where you have identical twins are sharing the placenta. One twin is getting more blood or more share of the placenta or more blood flow to it than the other. One gets like fluid overloaded, one gets dehydrated, so to speak. And so you have to go and laser. They have anastomosis between the blood vessels and the placenta. And anyways, you basically laser off these blood vessels and separate the circulations of the two twins. And I got to participate in that when I was at UCSF.
How cool is that?
Yeah, it's amazing. And the thing is that, so there's certain fetal centers throughout the country. There's not, and there's not so many of these cases that you need fetal surgery. And so it's not like a bread and butter kind of day-to-day thing. There's cases that come in, and so you need to be at a big fetal center or big referral center. And until a case comes in, you're doing, general NFM. And so I ended up coming back to be with family, and I miss Cedars a lot. I was here since the med student. Once you leave, it's very different out there. So I really wanted to come back.
So you don't do that stuff?
So no, I don't do that stuff. It's still, I watch it all the time online, or we used to be able to go shadow one of the surgeons out here, Dr. Schmeit. He's amazing. He's in Pasadena now, and is associated with USC. And then I've done some international rotations in London, where I got to observe some of the cases as well. I always joke around that I want to go back for fellowship for it. It's just a year or two. They have programs, then I'd have to leave everyone behind again.
And then you'd have to leave LA, right? Is there a major?
I have to leave LA, and I have a family, and now things have changed, and so. But I always, believe it or not, think about it all the time.
And so you also deliver babies, right? You still do general OB?
Yeah. So that's an important another thing you were talking about. You were mentioning earlier. So when it comes, so we talk a little bit about what we do in the office and fetal surgery and how I got into it, and by the way, I think that I love MFM, and I think everything happens for a reason, and it's very interesting how I ended up going into OB just from that one night, and then switching over to MFM because I couldn't imagine. I mean, I love what I do, and I'm great. I feel like I'm great at it, and I can't imagine doing anything else that I'm doing now. And so life is very interesting. I always tell the students and residents, remind them that you have no idea what you're going to end up doing. Anyways, the other half of what we do in MFM is hospital-based work. So we get consulted to take care of patients, high-risk patients in the hospital. And patients can be in the hospital for multiple reasons. Sometimes they're there the whole pregnancy. So, for example, I have currently a patient in the hospital who's been there for a couple of weeks because her baby isn't growing well. It has fetal growth restrictions, some complications from that. So she's on continuous monitoring in the hospital and probably be there till the end of the pregnancy. And that hopefully she's there for a long time and doesn't get delivered early and preterm. Patients can be in the hospital for bleeding. They can be there for preeclampsia or high blood pressure pregnancy. They can have uncontrolled diabetes, other placenta abnormalities, placenta accreta. They can sometimes be in the ICU, whether it's the flu or COVID or some other like liver disease. I mean, anything. We even deal with cancer in pregnancy. I've had patients. I think I consulted you for a patient once with thyroid cancer in pregnancy not too long ago.
Right.
I have brain tumors and breast cancer in pregnancy, all kinds of things like that. So that's the other half. Or we might be consulted for, issue during labor and delivery and to help with that or help with a complicated C-section. Now, depending on where you are in the country, high-risk pregnancy specialists, sometimes some do deliveries and some don't. I still do delivery for patients, and so I'm doing still the full spectrum. It's not the majority of the practice; it's a very small part of my practice still, but I expect it to be growing and doing more of that in the future. And so it's basically a mix. Now, I think in the LA community, it just depends on where you are. Most of the perinatologists are not doing deliveries here, but I am, and I know another one is.
So you yourself had a very ironic situation, right? You just recently had twins, didn't you?
Oh, yes. So the very ironic. My wife had twins, and which is twin pregnancies. That's another high risk thing we deal with. Twins and triplets. Sometimes quadruplets, so there's much less common these days. But yeah, we had twins, and it was a high risk pregnancy. She had issues with the babies. So when you have twins, you have the placenta or placentas has to feed two babies, or uterus has to feed two babies, and sometimes one or both don't grow as well. So we had issues with that. And then she broke her water, I think it was like around 30 weeks. The pregnancy was quite early, then was admitted to the hospital. And about 10 or 11 days later, around 31 weeks, she delivered. And then the babies were in the neonatal ICU for 2 months. This was during the height of the pandemic in May of last year. You know, it was difficult because they wouldn't allow us to go visit at the same time and whatnot. But I went through the whole high risk pregnancy and experienced the whole thing, and it really opened my eyes to be able to. I thought I was understanding my patients well, and I did, but once actually going through everything, I mean, all the medications we use and everything we have to use, it really opened up my eyes, and now I can connect with my patients on a much different level.
I bet it's probably made you such a much better doctor, right?
Yeah, absolutely.
And how old are your kids now?
A year and a half.
And they're both doing okay?
Yeah, they're doing great. Very cute, very beautiful.
Are they they're two girls or a girl and a boy?
Yeah, two girls. They're not identical. Yeah, and two girls and they're not identical. And then she decided that we should get pregnant 6 months after. So we have a 6-month-old baby boy.
Wait, you have another baby?
Yeah, so in between. I'm telling you, this COVID, it's really messed up communication with everyone because we don't get to see each other. Yeah.
I have 3 kids under 2 years old.
Yeah, so kind of like what I call like Irish triplets, I guess.
Yeah. Oh my God, you must be exhausted.
So my wife more than I, but yeah.
Wow, that's amazing.
Yeah, I mean it is hard because I used to wake up early, and I have to wake up early because I have to go help the baby give milk or get the baby to sleep. I used to wake up early and run to the hospital. Now I don't have as much freedom.
Wow.
But so yeah, we have 3 under.
Holy cow!
2.
Are you gonna have more?
Maybe one more, but to be determined. Maybe one more.
What's the oldest mom you've been involved with that's had a baby?
Oh, 55.
Wow.
55.
That was going to be my question too. I didn't expect it to be over 50. Okay.
And did it go totally fine, or were there glitches and stuff?
Yeah,
How common is that?
Usually, the most common complications in what we call very advanced maternal age are gestational diabetes, preeclampsia, high blood pressure, pregnancy, and early delivery. She did well. She ended up getting high blood pressure pregnancy, but otherwise, they do well. And we monitor them very closely, and I think it makes a big difference.
How common is pregnancy over 50 for you? Do you see it a lot?
Yeah, I mean, so especially in our community in LA, it's quite common to see definitely over 40s, like for sure over 45. Over 50 and over is less common, but we see quite a bit because again we get these patients referred to us, so we see quite a bit.
Right. And what's the most number of babies you've seen born?
Quadruplets.
Wow.
Which is very high risk.
Do those have to be C-sections or they're vaginal births?
Yeah. And triplets are higher. We recommend C-section.
I've had a lot of friends that have developed diabetes after they became pregnant. Why is that?
Yeah, so gestational diabetes is a condition that is diabetes in pregnancy. So there's pre-existing or pre-pregnancy diabetes, and there's gestational diabetes. And the difference is just if you had diabetes before you became pregnant or you got diabetes while you're pregnant. The pregnancy type is caused by the placenta giving off various hormones and factors which block your insulin in your body from working well. So decrease the ability of your insulin. They're basically blocking the function of your insulin. And so insulin is important to help the glucose, the sugar in your blood that you get from food, to go inside the cells and be used for energy. And so if the insulin is not working, then your sugar stays in your blood instead of going in the cells, and so your blood sugar goes high. And when you test your blood sugar, it's high, and so that's what diabetes is. It's having elevated blood sugar. And so the reason is that the placenta is making these factors that block the insulin from working.
Okay. And there's nothing you can do to prevent that. It just happens.
So it just happens. You can try diet and walking, but and improving, especially pre-pregnancy. If you're because so there's some of the risk factors are like having a family history of diabetes, being overweight or obese, and so or being older, and so which you can't change. But if you can improve your weight or diet and exercise pre-pregnancy, you can reduce your risks of getting diabetes. However, you can be totally fit and young and healthy and still get gestational diabetes. It's less common, but ultimately it's caused by the placenta.
So I have a couple of questions. One is, Lauren, I shared with Lauren an article about a woman who, and I think it's been going on now for a while already, who delivered babies after a uterus transplant. What's the story with that? What do you know about that stuff? How common is that?
So uterus transplant, there's not that many that have been done before. It's usually in women who don't have a uterus, or they have some kind of uterine anomaly or abnormality that develops later in life, like Asherman syndrome, with which causes like scarring of the.
Do you manage
uterus.
those? Would you be the doctor managing those?
Yeah, once they become pregnant. But it's not. No, we haven't had anyone at Cedars. They're done at specialized centers, and it's really investigational. So those patients are kept, within that facility wherever they got the transplant. But basically, you can get a uterus from a living or deceased donor, and it's usually in women who don't have a uterus to begin with. For example, there's a condition called Mayer-Rokitansky-Kuster-Hauser syndrome, or MRKH syndrome, or women with Asherman syndrome. If they have a uterus, then you need to remove that uterus before you transplant the new one. And then there's risk, like any other transplant, of rejection or infection or blood clots. And so they'll be on immunosuppressive protocols and be monitored closely. And then
when the baby's born, do they remove the uterus at the same time?
Yeah. Mm-hmm. Usually, yes.
Wow.
So you can actually donate a uterus? Like someone can give you their uterus?
So there's you can have living or a deceased donor.
Wow.
Do you think a man will ever get pregnant?
Yes, it's possible. I mean, I think in theory, if you can, I don't know. Okay. Well, I should say I'm not sure. It's so new.
Or or a trans patient.
Yeah, that for sure. I mean, well, some of those they retain. Depends on what kind you're talking about. Some of them, they can be male but originally female. They have
no, but I mean a male to female patient get pregnant. Get a uterus transplant and then have a baby. You think that'll happen?
I think in theory it may be possible. I don't know the science. I think though, in theory it's possible if you can get the blood. If there's enough, if you can figure out the circulation to feed the uterus, they probably would have to. And they make like a vagina. You can probably figure it out.
Wow.
Have you ever seen the movie?
I don't know that for a fact.
What movie?
We need to look that up.
Have you ever seen the movie Junior starring Arnold Schwarzenegger and Danny DeVito, where Arnold Schwarzenegger has a baby? Neither of you? It happened 30 years ago in this movie.
I may have seen bits of it, but I didn't know that he had a baby. Is Danny DeVito his baby?
No. I think he's like his friend or his brother or something. I forget what his role in it is. I think he's in it. But yeah, Arnold Schwarzenegger definitely has a baby.
Do you have any time ever to watch movies or TV shows?
No, honestly, if I have time, I'd rather go take a break, sleep, exercise, hang out with the kids, or eat.
Yeah, we always end with like a recommendation, like what you're watching, what you're reading. I mean, it could be like years ago. You have any
podcast or anything, like other than Gross Anatomy podcast that I know you listen to?
Okay, you know what? No, why don't we be honest? What do I watch at night before going to bed? I will be very honest. I check Instagram, and there's a few people's stories that I always watch. There's a couple of plastic surgeons. I just think they're funny. I don't even care. I don't do plastic surgery or anything. I just think that the doctors are funny and they're entertaining. And I watch Gross Anatomy, believe it or not.
Hey, all right.
I don't even know how I came this is how, I mean, I just ran, I don't know how I came by gross anatomy on my Instagram not too long ago, just like after all these years of knowing Jason, I had no idea he had gross anatomy.
Mhm.
And I still don't know how it came up in my feed. And then I added it. It had to just be a month ago. And then I saw Jason in the hall. I'm like, hey, I've been watching you. And then he's like, come join us for a podcast. And I look for gross anatomy every night to see what's on and what was. So my shows are really, believe it, I'm probably a lot of people is Instagram.
I've never had that answer
watch.
before. I like that one.
I love that. That's the
I'm being
best
honest.
answer ever.
Because you said if I can share something that I saw like years ago, but I'd rather be honest with you. Why years ago?
Yeah.
I love it.
Yeah.
Well,
But
and you
gross
said
anatomy is very funny.
you haven't started doing TikTok yet, watching TikToks yet?
So unless so I guess some people do TikTok and then they post it on their Instagram, then I see it on there. I don't have a TikTok account.
Right.
Actually, I tried getting one and then it was like too complicated figuring out who to add, and so I just if they show it on their Instagram, that's how I see it.
Yeah, I know. It's amazing how TikTok, you could just go, you could be looking at your TikTok and the next thing you know, like an hour has passed looking at videos.
The latest thing I'm watching is on gross anatomy is I'm still waiting for the ending of your story about this.
Story time Saturdays and Tuesdays.
But there's a story about it came and took pictures of you in school, and then the whole mafia thing, and I think it was your dad who tried to tell you to go on, and you said no, and there's still, I think, the last part left.
Yeah,
It's a
stay tuned.
cliffhanger.
I'm not,
Yeah.
no spoilers.
Yeah. Well, yeah, so that's how we always end. So do you have any other questions, Dr. Cohen? This has been very informative. I didn't know anything about maternal-fetal medicine before.
No, it's totally cool. I love it. Thank you,
Okay.
Dr. Rad.
Thank you very much. Appreciate
Thanks,
it.
Steve.
Thank you. Bye.
Bye.
That's it for this week. Thanks for listening to Gross Anatomy, and be sure to subscribe to our podcast so you can check out more episodes on the evolving sights, smells, and sounds of medicine. Gross Anatomy is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition.